Good afternoon, everybody. Now we'll be starting our class on clinical stroke syndromes, and we'll be dealing with the function of brain, and then learn how stroke affects various functions. In fact, it is said that neurology is learned by stroke. So, to understand stroke, it is essential for us to know the neuroanatomy, the vascular anatomy, the pathophysiology, and the various brain functions. Then stroke learning becomes much more easier. The older definition of stroke is acute neurological deficit of vascular origin, less lasting for more than 24 hours. But the new definition is central nervous system infarction is defined as brain, spinal cord, or retinal cell death attributable to ischemia based on neuropathological, neuroimaging, and or clinical evidence of permanent injury. This occurs over a clinical symptoms of central nervous system dysfunction, or it can be a silent infarction, so with no known symptoms. So now the understanding of stroke has evolved over years now, and it is, as you all know, that have been introduced already, that hemorrhagic stroke is 17%, and that is subarachnoid hemorrhage 41%. If you look at the ischemic stroke, the large artery occlusions are about 20%, and the lacunar are about 25%. Sorry, the embolic are about 20%, and still we don't know uh, about approximately 30% are cryptogenic strokes, and so ischemic stroke is a main problem. So this class will concentrate on learning about ischemic stroke in that. And you know, the brain is supplied by anterior circulation and posterior circulation. The internal carotid artery system has ophthalmic, anterior cerebral, middle cerebral, posterior communicating, anterior choroidal arteries supplying various regions of the brain, which we are going to see.
Spinal, posterior inferior cerebellar artery, and medullary artery. So these are the branches, and the basilar artery has anterior inferior cerebellar artery, labyrinthine, pontine, superior cerebellar, and posterior cerebral arteries. So these are the main blood supply which carries blood, oxygenated blood to the brain, and through these systems which are depicted here, internal carotid artery and the external carotid artery is not, but it is useful for anastomosis, the vertebral artery, and you can see much more clearly in the subsequent slides. We have entered, but we have enabled now. Right. Sorry. Then somebody is entering. So there is a. This is the system which the vertebral artery, and this is the anterior circulation of carotid system, which can there may be a stenosis, which may result in low flow to the brain, and vertebral artery and vascular artery can get occluded, causing strokes, which we'll study in due course of lecture. And the various branches of middle cerebral artery, which are seen on the lateral surface of the brain, are orbitofrontal artery, Rolandic, anterior parietal, posterior parietal, angular artery, posterior temporal artery, middle temporal artery, anterior temporal artery. You see, these branches are also to be, to some extent, remembered as we do for coronary circulation. And the middle cerebral artery, if you look at this, there are lenticular-striate branches which are supplying the basal ganglia, and of course M1 middle branch and M2 branch, and it supplies the lateral aspect. So this anatomy is also very important to understand. The medial aspect of the cerebral hemisphere is mostly supplied by anterior cerebral artery, which has got many branches, and frontopolar, callosal, marginal, pericallosal, and posterior parietal and splenial artery. And posterior cerebral artery stem, you can see here, it is supplying anterior temporal, hippocampal, and these branches anastomose with anterior cerebral artery and middle cerebral artery, causing a very luxury anastomosis. This is the visual cortex, which is supplied by the posterior cerebral artery stem. And there are some penetrating thalamus-ophthalmic paramedian branches which are visible here. And if you look at the distribution of the system, you see the anterior cerebral artery supplying lateral aspect and a strip on the medial aspect also. The most part of the lateral surface is supplied by middle cerebral artery, and the posterior cerebral artery supplies this much area. So these areas are to be mentally remembered for future learning. And if you look at the coronal section, you see the area that is occupied for hand, the arm, the trunk, the face, the tongue. So these areas, and this is the territory of anterior cerebral artery, and this is the territory of middle cerebral artery, and this is the territory of posterior cerebral artery. So depending on the location of the infarct, we'll have this function. Having learned the vascular structure, we go to the key physiological aspect. You all know that cerebral neurons are fully dependent on cerebral blood flow. There should be a constant supply of oxygen and glucose through blood to the various groups of neurons, and the perfusion pressure also should be optimal. And some few important aspects which you should know are: cerebral blood flow is about 45 to 50 ml per 100 grams per minute, means very rich flow. If it drops below 20 ml, then physiological electrical function of cells begins to fall. So that's one of the reasons when we get stroke. Cerebral perfusion pressure normally is 80 millimeters of mercury, which is mean arterial pressure minus intracranial pressure. If this cerebral perfusion pressure is falling below 50, then ischemia and reduced electrical activity sets in. So two parameters, either it is cerebral blood flow or the cerebral perfusion pressure as it happens in hypotension. If you look at the requirements of oxygen and glucose and how long they last, oxygen consumption is 3.5 ml per 100 grams per minute. If blood is blocked, the supply is blocked to the particular area, the oxygen will last only for 10 seconds. And similarly, glucose utilization is about 5 milligrams per 100 grams per minute, and it lasts only for 2 minutes. So that particular area will be deprived of oxygen and glucose and suffers damage irreversibly. So these are the key physiological aspects of the stroke, which you should know anatomy and physiology, and you have to remember to understand the stroke. The various functions of the brain are also important. Now, what is the loss to the individual? If each hour in which the treatment fails to occur, the brain loses as many neurons as it does in almost 3.6 years of normal aging. That means every minute if stroke is untreated, the average patient loses 1.9 million neurons, 13.8 billion synapses, and 12 kilometers of axonal fibers, causing devastating effect on the function of the individual. That's why now time is brain, and we have as early as possible. Luckily for us, from 96 onwards, we have interventions to be 4.5 hours, and also
We can intervene, and we can intervene, and then hello. Yeah. Hello. Yeah. Yes. That's it. That's it. Working. That's what. So this much damage that can happen. So we can always treat the patient within time windows, and that should be very very rewarding to the doctor as well as to the patient, because stroke is associated with long-term disability. Now you look at a valvular heart disease can give rise to stroke, like rheumatic heart disease, when we call it as cardioembolic stroke, and the cardiogenic emboli, they propagate distally and cause the embolic stroke. And if there is a stenosis, flow reducing carotid stenosis can cause low flow, and if this is blocked, you can have a internal carotid artery distribution stroke. Atrial fibrillation causes stroke because it gives rise to thrombus generation, and that thrombus can get dislodged and causing cardioembolic stroke. So these are the pathophysiology mechanisms which are very very important to understand. So let's before we go on to the anterior circulation stroke syndromes, this big picture of brain and its functions are important, because we are going to learn neurology by stroke. So you should understand the aspects of the brain. The brain anteriorly is devoted to action. The posteriorly it is devoted to perception. So anteriorly you have premotor cortex and frontal lobes. Posteriorly you have auditory, visual, somatosensory areas which are important. But similarly we look what is the dorsal and what is ventral. Okay, next slide. The left side we have language and praxis. This is the coordination of the motor programs is praxis, and language functions are on the left side. And on the right side you got spatial representation, and the prosody of the speech is on the right side. Dorsal is where pathway, that means ventral is what pathway. The dorsal stream identifies where is the problem, the ventral stream is what is the problem. You see, this is the calcarine cortex, and lot of visual information reaches the occipital cortex. So if you look at the functions that can be affected in stroke, it will be arousal and awareness. It can be in the frontal lobes, when the frontal lobe syndromes, which are disinhibition, akinetic mutism, and these things will occur, and or disorganization. In the if it is in the temporal lobes, yeah, what what happened? Ananya, what happened? Yeah, Ananya, what happened? Okay, so language, uh, vision and spatial attention, motor system, sensory system, all these functional aspects are affected in stroke. So you have to be very, very eager to learn all these functions before you understand the stroke, which has been sensitized to you by in the last class. And so next, if you look at the arousal and awareness, there is a ascending reticular activating system from brain which reaches, and this is the tactography picture, and you are seeing various tracts which are going up carrying impulses to the brain, and to keep the arousal intact in an individual. The top bottom approach, that is a frontal and parietal limbic attention modulation, the various areas lateral frontal association cortex, parietal association cortex, anterior cingulate and medial frontal cortex, precuneus, posterior cingulate, retrosplenial cortices, upper brainstem, thalamus, hypothalamus. They are all interconnected. There are so many networks that are connecting and coordinating the various functions of the brain. So we'll look into the exciting aspect of neuronal networks which may get affected. This is a brain network. You see the mesh that is laid out in the brain. Billions of neurons are interconnected. So if one area is damaged here, the effects are felt and remotely also because of the connections. That is called brain network, and the important networks are the language perisylvian network, which is the primary auditory cortex, the arcuate fasciculus, which will take it to the inferior motor cortex. So this is a big network, and that we can get affected in stroke, and you can cause aphasias in stroke. Aphasias can happen various other reasons also. Stroke also gives rise to because of the disruption of the, and the aphasia that results depends on which area is involved, like that. Then you have the limbic network or retentive memory. You can see the limbic network. The amygdala is situated, the hippocampal region. Then you can go, and this is the fornix, and you see the hypothalamus. These are all the limbic areas. That includes a medial aspect of the frontal. This is cingulate gyrus also, and this is the limbic network that carries our emotions, and frontal spatial cognition network. So you can get disturbances in this area, and spatial cognition also can be affected because of disruption. Prefrontal network, attention and behavior. The prefrontal area, which is very important, it has got a dorsolateral prefrontal region, orbitofrontal region, and medial prefrontal region, which can give rise to the various disturbances. Gentlemen, you understand what differentiate humans from animals is the frontal lobes. You see, every other animal also has auditory function, visual function, somatosensory function. What they lack is the frontal cortex, prefrontal areas, which are very well developed in humans and carry higher cortical functions in a big way. The occipitotemporal face and object recognition from striate cortex, the fibers reach the FFA, that is the fusiform face area in the fusiform. This is the ventral stream that is depicted here. There is a dorsal stream that it takes it to the somatosensory cortex. The angular gyrus which is present here will liaise with the supramarginal gyrus of auditory, where you can facilitate reading and writing also. So
So we can't hear you.
Sir, you're not audible.
Is it okay now?
Yes, sir.
Yeah, okay. Now the frontal syndromes are dorsolateral, that is disorganized. The mesial frontal, akinetic mute, orbitofrontal disinhibited. That means everything, the organized behavior with you is located in the dorsolateral aspect. And if that is disturbed, you develop perseveration, you develop stimulus bound responses, and you have a impaired digit span that indicates attention deficits. So I told you already, the frontal lobes are what distinguishes you from animals. Animals also have visual, auditory, somatosensory, everything, but they don't have the frontal lobes. Frontal lobes are given to human beings, and if mesial frontal region is what is driving you, that is the force which you are working, the everything. If that is affected, you become minimal akinetic mute, minimal spontaneous action and speech. The orbitofrontal region, if it is affected, you become impulsive and emotionally labile, and you start laughing inappropriately, and you may develop hypersexuality. So these are the functions that are disturbed when the frontal lobe strokes happen. And now the memory, various sensory stimuli are coming, like visual and auditory. They are in milliseconds, and they are reaching the frontal lobes, and this is what we call working memory, immediate memory, the ability to hold information across an undistracted delay. So I mean, if you are distracted, you lose this memory. The magical number 7 plus or minus 2, some limits of our capacity for processing information. So if you are given 7 numbers up to, you can remember them immediately if you are not distracted. That's what is called attention. And if there is a disruption in the attention circuit because of the stroke, again you lose attention. That is concentrated in prefrontal cortex, which I showed you. And afterwards, what happens? This is the short term memory, which is in minutes, and which, if you don't uh, rehearse it, then what happens? It becomes, then the second stage is long term memory, which you can hold for days and months. The memory not lost by distraction. Even if you are distracted, this memory is not lost, and this memory is because of hippocampus and Papa circuit. And if this memory, which you are now using to remember the task, the talk which I am giving, if you rehearse and recollect number of times, it will get consolidated and becomes a remote memory, though by more than 6 months. Memory of events of many months ago. This is a semantic knowledge. You got procedural skills, and this is distributed in cortex. It is not dependent on hippocampus for retrieval anymore. So the long term memory becomes remote memory, and all these aspects of memory can be disturbed if the memory circuits are affected in the stroke. So you can see the entorhinal cortex, the hippocampus, the fornix, which is taking it to mammillary bodies, mammillothalamic tract, anterior nucleus of thalamus, and cingulate gyrus. This is a Pepper circuit, and this reverberating circuit helps you in memorizing. Anterograde learning is possible with intactness of this circuit. If this is disturbed, then you'll have again a memory disturbances. And the procedural memory is another memory which may be retained even if you have a destruction of the Pepper circuit. So this individual whose anterior temporal lobe has been sected was asked to see in the mirror and learn this diagram. And next day also he was shown and asked to learn the diagram. First day he made many mistakes. By second and third day, though he forgot what he learned, but once he started doing, he made very few mistakes. This is the motor memory or procedural memory, which may be retained for a long time. That is only for interest sake. So that brings us to the language area, where Heschel's gyrus, the primary auditory cortex, and which will carry the information to the Wernicke's area or superior temporal gyrus, and here the angular gyrus links written word with the language, and the arcuate fasciculus will take it to the Broca's area in the left inferior frontal language production area. So these areas can be disconnected because of the stroke and gives rise to various types of language disturbances called aphasias: fluency, comprehension, repetition. So these are the three important aspects of the language disturbance. So whenever in speech assessment you have a dysarthria, that is pronunciation problems, articular agility problems, another is language, that is aphasia. So all three are affected, then it is global aphasia, large dominant hemisphere. The language function is usually in the left. 99% cases, the right handers it is left side. In left handers also, in the majority up to 70%, it's on the left side only. The Broca's aphasia is characterized by preserved comprehension with no fluency and no repetition inferior frontal gyrus. Transcortical motor, you always read with Broca's, it has repetition also preserved, and this is mesial frontal lobe. The Ventricus has got no abnormality in the fluency, but comprehension and repetition are disturbed in posterior superior temporal gyrus afflictions. And Ventricus to be always studied with transcortical sensory, which also has preserved repetition. So this is temporoparietal junction. The transcortical mixed things can have only repetition, no comprehension, no fluency. That is, both transcortical areas are affected in watershed infarcts. Conduction aphasia, repetition is not there. They have fluency, they have comprehension when arcuate fasciculus is involved. So this one table will make you remember all the aphasias and revise them: fluency, comprehension, and repetition. So that comes us to brings us to the most important aspect, which in stroke assessment we always neglect, that is a vision. You know, optic nerve, optic asthma, the optic tract, the optic radiation that goes inferior and ascends through the temporal lobe is Mayer's loop, and it reaches the occipital cortex. And you know the function of this. You have already understood that the problem with this retinotopic map is the central part of the central vision is hugely magnified in the striate cortex. This is the medial aspect of the occipital lobe. The central region you see is so much represented here. As you go, the representation becomes less and less, and ipsilaterally there is one part, that is monoocular crescent, is represented in the distal most part of the striate cortex ipsilaterally. So the monoocular crescent is characteristic of the ischemic the area of large cortical blindness. So you see the superior, the lower vertical median, upper vertical median are representing the visual areas represented above and below. So this representation, the depth of the calcarine sulcus is the horizontal meridian. So you have to remember these areas to understand what type of visual disturbances we can encounter. If there is an inferior occipital infarction, you can get left superior quadrantopia. Because this is the right side, you get in the left side. If you get a area left side temporal lobe is involved, you get right superior quadrantopia. If you have a problem in the in the pituitary region, suprasellar region, you got a bitemporal hemianopia. If you got an occipital stroke, the macular area, which has got a huge representation and bilateral supply, is not usually involved. So you got a macular sparing hemianopia, and that is a characteristic of occipital infarct. So the 47-year-old man with the difficulty reading and loss of vision to the right. Here you see what is called alexia without agraphia. That means he can write, but he cannot read. Why he cannot read? Because the information is not getting transmitted to the dominant hemisphere. As you can see here, that there is a disconnection of intact vision in the right hemisphere from the language areas in the left hemisphere. So you develop alexia without agraphia. One of the interesting observations, if a chap is not able to read but he can write, that is because the reading requires visual input. Writing doesn't require. Writing is inherent. You are thinking and writing. Whereas reading, you have to read and you have to transfer that onto the dominant hemisphere. Here there is a damage. So this is alexia without agraphia. So the visual processing is very, very important. As I said earlier, you see the wear pathway. This is the dorsal wear pathway and ventral what pathway. This is the fusiform gyrus, fusiform face area. If there are infarcts in this area or lesions, the individual will not be able to identify the faces. So you see, the brain looks and understands, and this fusiform face area is useful in identifying the facial features. Though before MRI everything, this has been described. You see, if you look at this, there are sorry. If you look at this the other way, then you can see a face also here. So this is a function of the FFA, and this facial recognition is lost if the fusiform gyrus is involved in the posterior circulation strokes and you develop prosopagnosia, right? Then comes the visual attention. One of the interesting things that strokes can give rise to is attention, visual attention problems. Let us understand what is visual attention. The left hemisphere has got the ability to shift visual or no ability to shift visual attention. It controls only right hemisphere. Whereas the right hemisphere has got a specialized for bilateral shifts in the attention. So the right hemisphere is specialized for bilateral shifts. You see the right hemisphere, and the attention can be shifted from here to here, whereas the left has got only on one side. So this understanding is important because the right hemisphere strokes are always associated with confusional states because they are not able to shift the attention from one visual hemisphere to the other side. Right, very good. So you see the right hemisphere region, only the left is visible, whereas for left hemisphere it is black, and the other, see, if it is on the left side there is no attention problem because the right hemisphere is able to shift attention from one hemisphere to the other hemisphere, right? Okay. So that's important about the attention. And how you can neglect is tested is by asking them to draw a clock. If the left side is totally missed in the diagram of also, this left side is missed. If you ask them to draw diagram, the left side is missed. That means one area is neglected on the right hemisphere strokes. See, in the right parietal hemorrhage is seen on CT scan. The CT is the reverse of MRI, the sidewise, and you ask him to make a cross across these lines, he will do only on right side. Suppose with eraser you erase all these, he starts doing on the right side only, leaving the left side. So the visual attention shifts are important. This is called anosognosia. Anosognosia means lack of knowledge about disease. If the individual you ask what is wrong with you in right cerebral hemisphere strokes, he says I don't have any problem. That is what is lack of knowledge or anosognosia, and you can detect it by doing these tests, that anosognosia. And what is anosodiaphoria is lack of caring about disease. He says, so what? Let it be there. No, that type of careless attitude is called anisophobia. So whenever this individual wants to try and clap, he wants to clap, but he cannot clap. He'll clap only with one hand. That is called East Chester clapping sign. This is how it has come into vogue. Is just one second. Hello, hello. So what happened was in a high school in New York, one bright student asked the teacher how an hemi-neglect chap or anosognosia chap is, if you ask to do a clap, he will do. Even the teacher doesn't know, and they have talked to some neurologists, they never thought about it. Then they went and checked in their ward, and they started clapping only with one hand. So that has become East Chester clapping sign, and this is easy to identify. If you ask a person in stroke to clap, if he says clapping with one hand, the other hand he doesn't know. So then what is a Balanit syndrome? The affliction of the striate cortex, and all around the striate cortex visual association areas are there. If there is an inability to perceive all the elements in a picture, I'll show you the picture. And if there is a poor reaching under visual guidance, optic ataxia, poor visual search for objects, these are all possible in Balanit syndrome, which is a affliction which we'll see in this case. See, if you ask to describe the cookie thief picture of Boston Diagnostic Aphasia Examination, where this boy is stealing a cookie and giving it to his sister, she is washing burtons and water is overflowing here, they will not be able to say the whole picture, but they will describe only a part of it. And this is Balanit's syndrome. So that is a visual association area damage which can be seen in the CT scan here. You can see that very nicely. Praxis, the coordinated motor programs. You don't know how, when you are buttoning, you are scissoring, you are telephoning, you are combing. No, there are so many coordinated actions take place, and these coordinated actions are also controlled in particular area on the left side, that is a praxis, the parietal area, which is connected to ipsilateral supplementary motor area, which is also connected to the contralateral supplementary motor area through corpus callosum anterior segment. And if there is any disruption in this, you develop apraxia. That means no motor sensory deficit, a learned motor activity you will not be able to perform. That is apraxia. So now you see the simple diagram: praxis, supplementary motor area, and any part, if there is a disconnection, you will develop apraxia. So that brings us to the motor homunculus, and you see the leg area in the anterior cerebral artery territory. So if there is an infarction, you get leg more than arm. The middle cerebral artery has got a huge area, so you get a face arm more than leg. You see, this is a face and the arm. This is a middle cerebral artery which has got more of face and arm than leg, and anterior cerebral artery leg more than arm. And if there is a border zone, man in barrel, proximal arm weakness in this area. So a differential weakness in hemiparesis tells you that it is a cortical stroke, not internal capsule stroke, and which we'll see in the internal capsule stroke subsequently. So this is what is the sensory system. The post central gyrus also supplies, the homunculus is depicted here. The cortical sensations are 2-point discrimination, graphesthesia, stereognosis. These three are characteristically disturbed in the presence of intact touch, temperature, and sensations. So these cortical sensations are affected if there is a stroke in the post-central gyrus. The central seventh nerve palsy, the upper part of the face is not involved, but the lower part is involved because the upper part of the face has got bilateral representation. So in a hemiparesis, for example, left side or right side hemiparesis. The speech is also disturbed because there is involvement of Broca's area. Also, the face is drooping on the same side of hemiparesis on the lower part. By upper part is not involved because it's a bilateral representation. Not only that, the emotional aspects of the putamen, globus pallidus, and amygdala also send impulses to facial nucleus, and those are different from motor inputs that are coming to the facial nucleus. So an individual who has a facial palsy can smile fully in emotional circumstances. So that if this is disturbed, then it is called emotional facial palsy if you are not smiling. So this input to the facial nucleus, both from motor cortex and the limbic areas, is also important to remember. So this makes the study very interesting. You have looked at the big picture. We looked at the arousal and awareness. We discussed about frontal lobe syndromes. We also discussed about memory, language, and various visual field defects. And we talked about spatial attention, anosognosia, and praxis and motor systems, and various disturbances that can occur depending on the vascular territory involved, and somatosensory processing thing about graphesthesia, stereognosis, and 2-point discrimination. So these are all the functions that you should know before we go on to the occlusions, which is the next part of the talk which we are going to do. And to identify that large vessels are occluded or small vessels are occluded, we should be able to differentiate by Van scale, visual disturbance, aphasia, neglect. If these three are present in any case of stroke, a large vessel is occluded. Nowadays, that occlusion can be removed, that thrombus can be removed with mechanical thrombectomy. So every one of you should know what is a Van scale, and when a person is weak, how weak is the patient? You make him raise both the arms up. It is a minor drift, severe drift, and flaccid. And if patient shows no weakness, then Van is negative. If there is weakness, then you look for the field cut, which side the visual problem is there. Is there any double vision? Is he blind? And then also you look for aphasia, whether comprehension is present, whether fluency is present, and whether it is mixed or none. Then you look for the forced gaze or inability to track to one side, unable to feel both sides at the same time, and ignoring one side. All these features will tell you neglect. So that these three examinations will tell our stroke is because of large vessel occlusion, and we should involve. See, the large vessel occlusion strokes means we have already known these areas, and these areas, if they are damaged, will give rise to disturbances in a Van scale. So these are the arteries that can be disturbed. Now we'll go to the clinical stroke syndromes. The large vessel occlusions are anterior and lacunar. So these are the important large vessel, and we'll try and remember some of these. We try and remember whatever we learned so far about the brain functions, and try and identify in the vessel disturbances. The cortical branches, the MCA is divided into cortical branches. Proximal MCA is called M1, which will give rise to lenticulostriate branches. Distal MCA M2, superior and inferior divisions. I will identify, and this can be occluded due to embolus. It could be artery to artery, or it could be cardiac, or it could be because of intracranial atherosclerosis, when collaterals will prevent some damage. So, what are the features of middle cerebral artery? The M1 segment occlusions. M1 segment of contralateral facial arm weakness more than the leg weakness. You remember homunculus? It will be dominant hemisphere. There will be aphasia, a contralateral sensory loss, cortical sensory loss in non-dominant hemisphere. That is, you will have graphesthesia, contralateral visual field defect, gaze deviation ipsilateral to the lesion, because the gaze is frontally located, the control of the gaze, frontal gaze center, and that is disturbed on the side of the damage, so the other side pushes the eyes towards this side, so gaze is deviated. This is the M1 segment. So this is a large MCI infarct which you are seeing, and this is the ADC map, and this is the DWI image on MRI, how it looks. The complete MCS syndrome at origin will give rise to hemiplegia, hemianesthesia, and conjugate eye deviation, homonymous hemianopia, global aphasia, and if it is non-anosognosia, dressing apraxia, constructional apraxia, impaired ability to judge distance, and hemi neglect if it is on the right hemisphere. And there may be, that is because the non-dominant hemisphere will give rise to this dominant hemisphere aphasias, optic radiations, homonymous hemianopia, frontal eye field, conjugate eye deviation, somatic sensory area, hemianesthesia, somatic hemiplegia. So it is easy to remember. It's like a mathematics. You can easily remember the anterior division. Middle cerebral artery divides into anterior and posterior divisions. Contralateral facial and arm weakness more than the leg weakness, and Broca's aphasia. The anterior, the posterior division, contralateral sensory loss, and here Wernicke's aphasia comes. Here there is no weakness. You may come across just one syndrome on the dominant hemisphere, and on the non-dominant hemisphere you can get cortical sensory loss or neglect and contralateral visual field defect. This is the middle cerebral artery posterior division. So middle cerebral artery can be, the whole thing can be occluded, the superior or anterior division, or the posterior or inferior division can be occluded separately on M2 branches. The partial, though, you get a partial MCA syndromes. If it is superior division, brachial syndrome, Broca's aphasia, frontal opercular syndrome, or faciobrachial weakness. You can, if it is inferior division, Wernicke's aphasia without weakness, and on the dominant sphere, you get a jargon speech, contralateral homonymous, and superior quadrantopia in the dominant hemisphere, hemi-neglect in the non-dominant hemisphere. So we learned what is hemi-neglect, what is this before learning this. So now I hope you will be able to understand the Gerstmann syndrome is finger agnosia, acaliclia, agraphia, right-left disorientation. This is because of the left-sided angular gyrus involvement, which is considered as the most important heteromodal association area in the posterior region. And that brings us to the second, anterior cerebral artery. The branches of anterior cerebral artery is the A1 segment are communal, post-communal A2, cortical branches, penetrating branches, anterior limb of internal capsule, anterior perforated substance, amygdala, anterior hypothalamus, inferior head of the caudate, anterior part of the globus pallidus, and recurrent artery of Hubner is the largest branch which supplies the caudate nucleus. So the infarction less common, usually suffer after SAH, subarachnoid hemorrhage from anterior cerebral artery and anterior communicating artery, and occlusion of the proximal ACA is well tolerated because it's a dual supply on both sides. So what happens in this? As we learnt earlier, leg weakness is more than the face and arm, because the homunculus, you remember, the leg is on the medial side. Contralateral leg sensory loss, apraxia, abulia if it is bilateral, and contralateral hemiparesis involving foot and leg because of motor leg area involvement. Sensory area for foot and leg is involved. Cortical sensory loss involves the foot and leg, where you have to test for graphesthesia and stereognosis. Paracentral lobule is involved. You will have urinary incontinences, and there will be contralateral frontal lobe release signs, Gegenhalten, because of the involvement of the supplementary motor area. And as I said, if it is a medial aspect, you get bilateral mesofrontal damage, akinetic mutism. We learned three aspects: disorganized behavior, akinetic mute behavior, disinhibited behavior. Disorganized dorsolateral, medial is akinetic mute, and basal is disinhibited. There will be memory and emotional disturbances, and transcortical motor aphasia, where you have preserved repetition. In aphasia testing, repetition is a very important test. So that shows dominant lobe involvement, anterior disconnection syndrome with left arm apraxia, because as I said, the praxis is on the left side parietal lobe. The impulses are carried to supplementary motor area on ipsilateral side and also to the contralateral side through the corpus callosum. So any connection disturbances will give rise to apraxia. So SCS syndrome, recurrent artery of Hubner, will cause weakness more pronounced in the face and arm without sensory loss due to involvement of the anterior limb of the internal capsule. Now I am going to tell you that internal capsule blood supply is very important, which I am going to give you in the next few slides. This is the infarct in the recurrent artery of Hubner distribution. This is the recurrent artery of Hubner, which is a branch of anterior cerebral artery. Anterior choroidal artery is a branch of ICA. It supplies the posterior limb of internal capsule. So you are learning two new branches. And what happens? This artery can be damaged in surgical clipping, and it causes contralateral hemiparesis because of posterior limb of internal capsule. It may cause hemianesthesia. Posterolateral nucleus of thalamus is involved. Homonymous hemianopia because the horizontal meridian is spared in this. Recovery is substantial, happens normal cognition and language function. So let us see how the image looks in anterior choroidal artery, and this were the features we have already said, and that's how it looks. The image in the FLAIR MRI looks like this in anterior choroidal artery infarctions. Internal carotid artery can be totally occluded, artery to artery embolism, or could be because of fixed obstruction, which I showed you. Varied presentation depending on how the flow, the thrombosis, the embolism happen, and it can propagate into MCA, this is called distal propagation. It causes a massive infarction. As a warning sign, amaurosis fugax occurs in 25%. That means as if a curtain is drawn in front of the eye. It is always unilateral, it is a transient, it improves. And there is a visual loss which is transitory, happens as if a curtain has fallen in front, that you should think of amaurosis fugax and internal carotid artery occlusion. He can be saved by before developing a full-blown infarct. Ipsilateral retinal ischemia, sensory motor dysfunction similar to the involvement of both MCA and ACA territories, easy to remember if it is total internal carotid artery. However, there is a presentation that is sometimes you have a classical triad of pain, Horner syndrome, and cerebral ischemia of, I said, dissection. If internal carotid artery, the inner layer is dissected or the intima is ruptured, blood enters in beneath the intima and between intima and media, then there will be pain, Horner syndrome. Disturbance. So this is seen in injuries and may happen sometimes also. So large vascular occlusions of posterior cerebral artery type will have discussion in the next class, where we discuss about brainstem syndromes, contralateral sensory loss because thalamus is involved. I showed you the distribution of the posterior cerebral artery. Cognitive dysfunction also because of thalamus, thalamic aphasia, and visual dysfunction as per post communicating segment. And there are some branches which are important, and there is a single artery of Percheron which can supply bilateral thalamus. So this is the artery of Percheron infarction, and if this happens, the individual will be sleeping a lot or morose, and this type of MRI picture is seen because of the abnormality of the thalamic perforators. The posterior cerebral artery is connected with posterior communicating artery in the circle of Willis, and there are some perforators. If these perforators origin from one side, that is called artery of Percheron. So large vessel clinical syndromes, posterior inferior cerebral artery and Horner syndrome, ipsilateral hemiataxia, palatal weakness, hoarse voice, decreased pain and temperature on the ipsilateral portion of the face, and contralateral limbs, what we call as Wallenberg syndrome. And anterior inferior cerebral artery, which is a branch above, ipsilateral deafness, ipsilateral facial weakness, ipsilateral hemiataxia, hoarse voice, contralateral sensory loss in limbs. This is the more understanding will come in the next class when we tackle brainstem. And superior cerebral artery, ipsilateral ataxia, decreased sensation contralaterally, and diplopia, because various ascending tracts and descending tracts are disturbed in the brainstem, you will get a large vessel occlusion. And basilar perforators, median and paramedian pontine perforators, if they are occluded, there will be contralateral limb weakness if it is unilateral, quadriparesis if it is bilateral. Hemiataxia, because of the pontocerebellar fibers, that is dentatorobothalamo-cortical tract disturbance or cortico-pontocerebellar tract disturbances, which are the connections between cerebellum and the cerebral cortex, and cranial nerve 6th and 7th affecting the nuclei or nerve fibers, and internuclear ophthalmoplegia, because the 6th nerve nucleus is connected to the 3rd nerve nucleus, which is in the midbrain through median longitudinal fasciculus, which can get affected in the infarction because of the basilar perforators. The midbrain basilar posterior cerebral artery perforators also will give rise to these features, which is in the cranial nerve third palsy, and we have Weber syndrome, which we will discuss next time. There will be contralateral facial arm and leg weakness because it's happening before the pyramidal decussation. The rubral tremor because of red nucleus involvement and decussation of superior cerebellar peduncle will give rise to ataxia. So these are all the symptoms which one encounters, and you have anterior spinal and vertebral artery perforators to the median and paramedian medullary region, which will give rise to tongue weakness. 12th nerve nucleus and nerve fibers are reflected here, and medial lemniscus is involved, so contralateral arm and leg have reduced vibration sensation and proprioception, and contralateral arm and leg weakness because of the medullary pyramids. That means you have to understand the anatomy at medulla, pons and midbrain thoroughly. You please come prepared for the next class, which we are going to discuss at length those. That brings us to the last part of the talk, these lacunar syndromes, which are small ischemic infarctions in the deep regions of the brain or brainstem because of the end arteries, 0.5 to 15 mm in diameter, that is 1.5 centimeters. They result from occlusion of penetrating arteries. The common identified are pure motor hemiparesis, pure sensory stroke, sensory motor strokes, dysarthria clumsy hand syndrome, ataxic hemiparesis. These are very things which have been mentioned in the previous class also. The pure motor hemiparesis, internal capsule, basis pontis, corona radiata. Here contralateral hemiparesis or hemiplegia involving the face, arm, to less extent legs with dysarthria. Now how do you identify? There is no aphasia here. If aphasia is here, it is large vessel occlusion. So this is, if there is no speech or language disturbance, that means language disturbance, it becomes pure motor hemiparesis. Similarly, if a nucleus of thalamus, we have ventroposterior lateral nucleus, you get a pure sensory stroke, and this is the center for crude sensations of temperature, pain and touch. The sensory motor stroke, internal capsule and thalamus can give rise to both types. Ataxic hemiparesis, that means same side you have hemiparesis, same side you have ataxia, happens in posterior limb of internal capsule and basis pontis. And dysarthria clumsy hand syndrome, deep areas of basis pontis. So now this important diagram, the internal capsule blood supply. The middle cerebral artery supplies superior half of the internal capsule. The posterior inferior part is supplied by anterior choroidal artery, ICA and PCA, and anterior part is supplied by anterior cerebral artery, and middle cerebral artery region is above. So ACA, MCA, anterior choroidal artery all supply the internal capsule, which is very important for you people to remember. So anterior limb, straight branches of anterior cerebral artery, the posterior limb, medial and lateral straight branches of MCA, genu straight branches of ACA, sublentiform central branches of anterior choroidal, retrolentiform posterolateral branches of posterior artery. So the diagram you remember at least most of the times you will be, the last line is a capsular warning syndrome, and this is a clinical syndrome defined as a recurrent
restricted to the region of the internal capsule, causing symptoms affecting face, arm, and leg. The ischemia most often is due to hemodynamic phenomena and in between the single small penetrating vessel.
sorts of these weaknesses. So that brings us to the last part. I want you people to assess the severity of the stroke by learning about the NIH stroke scale, which can be accessed and training can be done, and you can get a certificate. And this is the certification link which you can take a snapshot, and all of you get trained in NIH stroke scale, and you get a certification like this, and which I have done second or third times. We keep on doing it to improve our skills in the clinical examination. The students are immensely benefited if you do NIH stroke scale certification. Anybody wants to know about more, you can come and discuss with me. So that will bring us to last slide. CT with or without MRI, it is anterior circulation stroke, and you have to look at the carotid dissection is there, then anticoagulation versus antiplatelets. It is atherosclerotic stenosis, 100% only antiplatelets. If it is 70 to 99% by non-invasive imaging, that is Doppler studies, or more than 50% by invasive imaging, that is conventional angiography, you plan for a surgery called carotid endarterectomy or carotid angioplasty. If the stenosis is less than 50%, now this is, you can, again you have to be, it can give rise to two things. Look at the posterior circulation, known major cardioembolic source is there, anticoagulation. Lacunar stroke are not on any anticoagulation candidate, you do with antiplatelet agents. So if you get a non-lacunar stroke and you got an abnormal chest X-ray, ECG, suspicion of cardioembolic source, you do a TTE, transthoracic echocardiography, and treat appropriately after the diagnosis. So TEE is an important thing in cryptogenic stroke. So that's all from my side about the clinical stroke syndromes. And if there are any questions, you can ask. Otherwise, you can write to me on my email, and we can discuss more if you are afraid of asking at this juncture. So I just wait for a minute before I close. It's already 2:03. Okay, I think that that is I take that you have followed. I tried telling you what are the various areas of the brain that you should know before you approach the stroke. We divided the stroke into ischemic stroke in large vessel and small vessel. We tried identifying what are the clinical features of major vessels, middle cerebral artery, anterior cerebral artery, and a few posterior cerebral artery syndromes. Okay, and we tried telling you a lot about the functional aspects of the brain in this class, because the previous class Dr. Bhushan has already highlighted about various types of strokes, ischemic, hemorrhagic, and others. And next time we'll learn more about brainstem anatomy and strokes. So neurology is learned stroke by stroke. So this time we concentrate on cortical strokes, and the second class we will concentrate on brainstem strokes with a bit of viva and try and understand more anatomical facts. And neurology is like mathematics. You should know the anatomy, should know the physiology, which we touched briefly before going on the functional aspects. That will help you immensely. Thank you very much. Have a good day. Bye.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.